Hi, welcome back. In this lecture, we want to start taking a look at some clinical issues. And in particular, we want to start out by taking a look at evidence-based practice. When you think about evidence-based practice, there's a real challenge when it comes to medical progress. When we think about medical progress, it evolves in several different places. It evolves in terms of laboratory experiments that are taken in the laboratory setting, which are often referred to as bench studies. There's clinical trials that take place when we think something works and we get an idea of the benefits of something based on bench research. Quite often that moves to a clinical trial, and that's especially the case when we're talking about pharmaceutical agents. And then there's the transition between laboratory clinical trials and actual practice. And along the way, things can break down, or things can actually have different outcomes than are expected when we initially start out looking at a new modality. So what we see in the laboratory may not transition well into clinical practice. So we want to talk about that translation process a bit in this lecture. When we think about evidence-based medicine, it really is the cure to a wide variation of clinical practice. What we would like is to have researched, well-defined methods that can be followed by multiple people. Now, at first glance, that may seem like we're trying to create the cookbook of actually taking care of patients. But the reality is, when we learn something that works and learn a best practice, we'd like to be able to implement that. However, we have to be very careful about that we don't do something referred to by Jeffrey Pfeiffer, who is an organizational theorist from Stanford University. He refers to it as casual benchmarking. So we'll talk about that more as we go through. The major tools that result from looking at evidence-based are clinical guidelines. And again, these guidelines, where it departs from being a cookbook, is actually an attempt to try to create kind of a best practice based on the best scenario without completely taking away the idea that variation exists. Variation exists in everything we do. We need to be able to make changes to clinical guidelines based on certain patient parameters. However, for most patients, the majority of patients, clinical guidelines serve the patient in the best way. So the Institute of Medicine has actually defined it as systematically developing statements to assist practitioners in patient decisions about appropriate health care for specific clinical situations. And at this point, there's about 4,000 clinical guidelines that exist. Even with that number of clinical practices, we still see very wide variations in treatment modalities between practitioners sometimes. The resistance, again, is the concern that you're taking away the autonomy of a caregiver. If you look at physicians, they're really taught to take responsibility for the patient in a very individualistic way. Quite often we do the same. We think that we take care of one patient at a time and each patient deserves our best care. Unfortunately, our best care often is what's better for the aggregate, what we learn from looking at the aggregate of patients. I actually had a physician one time tell me that I was trying to create the McDonald's of healthcare in terms of EMS. And the reality is, yes, that is exactly correct. I mean, even though we know that the intake of McDonald's is not healthy for the human body, the reality is, from a business point of view, from an operational point of view, McDonald's does a really good job of making sure there's consistency. So no matter where you go in the United States or abroad, and you order a cheeseburger at McDonald's, you know what you're going to get pretty much. There's very little variation. If we could do that to some extent between providers, that would actually be good. However, we have to be careful about that, because when we talk about doing something such as that, quite often what happens is there's a real reduction in innovation that takes place, because the idea is that everyone's doing the same thing. So when we do to make a decision to make a change for the sake of improvement, quite often that takes a long period of time. That's definitely been the case over the last century in terms of the last century in looking at EMS. If you look at states that have implemented a structure whereby they have one set ideal of protocol for pre-hospital care, in some states, the way that actually evolves is that before any changes can be made to protocol, every provider within that geographical boundary has to be updated to the new level. Well, the problem with that is by the time you update all of those providers throughout an entire state, some of the providers that got the education early may have completely forgotten what they learned during that interaction. So there's definitely some things that have to be taken into consideration in terms of thinking about centralizing everything as being the best practice. It really goes all the way back to the stuff we talked about in terms of system design, and we talked a little bit in one of the lectures about centralization versus decentralization, and that's definitely the concept here in terms of how wide spread clinical guidelines are implemented and how they can actually be changed. So with clinical guidelines, a lot of people look at it and see that there's a lack of variation, as I was saying, and because of that, they kind of turn their nose up to clinical guidelines, if you will. Now, custom and standard care, all clinical care is a mix of custom and standardized care. What we have to do, as I was just saying, is actually balance that to determine what's the best in terms of standardization and what's the best in terms of customization. If you think about many of the practices you have, let's take a standard that's existed for a long period of time in EMS, the American Heart Association Cardiac Resuscitation Guidelines. That transition period of new innovation can take as much as 10 years. As an example, for more than 20 years now, the state of Washington, primarily Seattle area, King County Medic 1 program, and Houston, Texas, have ventilated patients very differently than everyone else that I was aware of in the country. So for 20 years, they've been ventilating cardiac arrest patients less than 10 times a minute. That's a current practice, just made it into the American Heart Association's last update. When you think about clinical standards, think about a bell curve. The standard is the middle of the bell curve, meaning there's some performance below and some performance above. Unfortunately, if you want to be the exceptional state of the art, the standard is often not the state of the art. It's actually well beyond that. So again, you've got to figure out how you're going to transition between this standardization and this customization. Because if you go to your medical director and say, we want to implement this new practice that's outside of the American Heart Association standards, there's definitely some questions about that, as there would be, and you have to be prepared for if you implement it and then there's any legal issues that arise as a potential result of that. So let's say in the example of the cardiac resuscitation patient and ventilation, you're ventilating patients at 6 times a minute, which is actually an ideal when you have very low coronary perfusion pressures. So let's say 6 times a minute, but this traditional standard was 20 times a minute or more that you found in textbooks such as the Heart Association's ACLS text, or let's say it's a traumatic arrest in pre-hospital emergency care or pre-hospital life support, pre-hospital trauma life support, or basic trauma life support. Often those texts said 22 to 24 minutes. While there was absolutely no scientific basis for those numbers that ended up in those books, most people would accept that as the standard of care. And going outside of that and ventilating at 6 times a minute may be considered below the standard of care or outside of the standard of care. So you, as a clinical manager in an organization, have to think about those concepts and think about how you're going to progress. So that's what we're talking about in this presentation and the other presentations this week. There's definitely financial implications in terms of evidence-based medicine and practice. If we could, for example, get all physicians to agree, not even agree, if we could get all physicians to buy in to the best practice for treating urinary tract infections, then you could see it would monopolize the use of one set of pharmacological agents in terms of treatment, because the demand would go up greatly for that. Quite often you'd see the price come down. So the treatments would become much cheaper in the long term, much more routine, much easier to get treated. The treatment path would be much faster. You would see more resolution of urinary tract infections, patients with better outcomes. So definitely all of those things, multiple places there's a financial implication to it. And you would see a benefit, a tremendous benefit, by the way, in terms of finances of healthcare. So I want to stop there in this lecture, and we'll pick up talking more about evidence-based medicine in the next lecture.